So I'll introduce our next speaker, Dr. Rachael McLean. Rachael is a public health physician and a senior lecturer in public health and epidemiology in the Department of Preventive and Social Medicine here at the University of Otago. And of course, she's here today to speak about measuring population sodium intake and is very well positioned to do so, given her research program in both the assessment of sodium intakes as well as her advocacy efforts in policies and strategies in this very important area today. So please join me in welcoming Rachael.
Thank you, Lisa, and thank you to both Ros and Catherine for really interesting talks that fit perfectly with mine. So I'm going to talk about sodium today, and my first task is to convince you that sodium deserves a talk of its own after all these interesting general talks we've had today. I'm going to talk about some of the relevant research and recommendations for measuring sodium intake, with a particular focus on populations, but inevitably have to mention measurement in other contexts, particularly cohort studies. And just a note that most of my measurements are to do with sodium, so I'm talking about grams of sodium. If you're more used to thinking about salt, multiply the amount of sodium by 2.5 and you'll come up with an estimate of salt. So I'm sure everybody is very familiar that a high sodium intake is associated with a number of adverse health outcomes. The evidence around elevated sodium intake and elevated blood pressure is very robust. There are many, many randomised controlled trials that have shown this in adults and children. The evidence around some of these other health-related outcomes is more diverse, so cohort studies, mechanistic studies, trials with surrogate endpoints, and a few randomised controlled trials in the case of cardiovascular disease that directly link high sodium intake with ischemic heart disease and stroke in particular. Is it controversial? Well, of course. Most nutrition topics have controversies associated with them. This is one of my favourite illustrations of this. This is from a newspaper in the United Kingdom, published in 2011, after a Cochrane review of sodium intake and health outcomes concluded that there was insufficient evidence of a direct association between sodium intake and mortality. And unfortunately, the media and indeed the press release from the group of researchers confused insufficient evidence with evidence of no association. But controversies are widespread in any sort of nutritional field, and often underlying this is conflict of interest and vested interests by members of the food industry. And sodium is no exception. And here is the Salt Institute saying that 5 out of 5 ER doctors agree that no electrolyte is more essential to human survival than salt or sodium. So why does sodium deserve a talk on its own? There's a strong evidence of an association with cardiovascular disease and elevated blood pressure. And cardiovascular disease, as we heard yesterday, is a leading cause of mortality and morbidity around the world. Despite reductions in mortality in recent years in high-income countries, increasingly an important cause of mortality and morbidity in low and middle-income countries. Japan, China and Korea particularly have high incidence of stroke, and Western countries have high incidence of ischemic heart disease. We also know from modelling and other studies that sodium reduction is a particularly cost-effective intervention for reducing cardiovascular disease. And here's an example of a modelling study that shows that, and concluded that modest reductions in dietary salt could substantially reduce cardiovascular events and medical costs and should be a public health target. We also know that we can do it, and many countries have demonstrated this. This has some data from Finland, which introduced a salt reduction program in the 1970s, and you can see an important reduction in salt intake or sodium intake over the next subsequent 30 years. Japan has also had a successful sodium reduction strategy, and as has the UK. which implemented an effective and comprehensive population sodium reduction program from 2003, led by the Food Standards Agency. So sodium intake was monitored in subsequent years, and it was demonstrated that there were reductions in population sodium intake of about 15% over an 8-year period from a series of population surveys. And you can see that on the left there. My apologies for the non-zero graph. It's a particular bugbear of mine. Blame the BMJ. Oops. This program has also been evaluated. I mean, this is observational data, but it was noted that over the period there was about a 40% reduction in mortality from stroke and ischemic heart disease, and a 3 millimetres of mercury reduction in systolic blood pressure. And when the authors of this paper looked at a wide range of risk factor data, they concluded that most of the reduction in systolic blood pressure was due to salt reduction, and concluded that the sodium reduction program had had substantial benefits on a population level. Importantly, they also, in the UK, monitored sodium concentrations in a wide range of foods and matched those with a series of voluntary targets across a large range of foods with a sinking lid over time. And so here's an example of changes in the salt content of bread. So it's really important not to just monitor sodium intake in people, but also monitor sodium intake in food. And I'm not going to talk a lot about that today, but I just wanted to note that that's an important function as well. So what is a high sodium intake? I've included 3 relevant guidelines. The New Zealand and Australian nutrient reference values have recently been revised. We no longer have an upper level for adults. And the new suggested dietary target, which is defined as the recommended population median intake from food and beverages that will help in the prevention of chronic disease, and is now 2,000 milligrams of sodium per day. And it aligns with the WHO recommendation for adults and the mean population sodium intake for adults. The US dietary guidelines are slightly different, as you can see. They recommend that adults have a sodium intake of less than 2,300 milligrams per day, while those at high risk should limit their intake to 1,500 milligrams per day. Unfortunately, the majority of the world's population consumes far in excess of what these guidelines recommend. And this is some data from a Global Burden of Disease study, estimates from 2010. You can see it's estimated intakes of sodium across the age range. And here in green is the WHO recommended level of 2,000 milligrams per day. And the global mean sodium intake is almost double that at 3.95 grams per day. And this is particularly problematic when you think about doing trials in population groups. It's very difficult when the norm is to consume double the recommended intake to get people to consume low sodium diets. But all of this together has led WHO to include sodium intake as one of its best bets for reducing non-communicable disease. This is the Global Action Plan for 2013 to 2020, and you can see here that they recommend a 30% reduction in population sodium intake by 2025, and member states have signed up to this commitment. You can see here obesity is much less ambitious. Halt the rise in diabetes and obesity, and I think that's a reflection in the fact that no country has managed to achieve that yet, whereas we know that we can reduce population sodium intake. So, what does New Zealand need to do? We need to measure sodium intake at baseline, preferably in a representative sample, using an appropriate measure, and we need to identify important food sources of sodium. We need to use this information to inform a national strategy for lowering population sodium intake. And that's in grey because I'm not really going to talk about what that might look like today, and also because we don't have one. Once we have a national strategy up and running, we need to monitor and evaluate. We need to incorporate measurement into existing health and nutrition surveys and or undergo just discrete sodium monitoring surveys using an appropriate measure, and we need to monitor sodium concentration in food according to specific targets. And then we need to use this information to reflect on the national strategy and adapt the national strategy where appropriate. So what is an appropriate measure? And I quite like this sort of diagram. I have it on my notice board in my office. But ideally we would have a measure that is reliable and valid. Yep. Here. We might be able to accommodate a measure that was reliable but invalid as long as we had information about that and we knew where the invalid measurement came from, or an unreliable valid measure, be up there on the top right, but preferably not an unreliable and invalid measure. It's important to keep in mind that measuring sodium intake has different requirements in individuals and populations. So if we're interested in the usual intake of individuals, as we would be for an epidemiological study, due to the high day-to-day variability, we need between 3 and 10 days of measurement in each individual to get an estimate of usual intake. If we're interested in population levels of intake, the main requirement is that we have an adequate sample size, preferably representative, and you've heard already that some members may have a duplicate measurement. Excuse me. So how can we measure sodium intake? Well, the gold standard measure is a 24-hour urine collection because we know that on average 90% of ingested sodium is excreted in the urine as a recovery biomarker. Various people have experimented with urine collections less than 24 hours, so overnight urine or 12-hour urine collections. I'm going to talk quite a bit about spot urine later in my talk, and Catherine has given us a lovely explanation of dietary assessment methods, food frequency questionnaires, weighed food records, and 24-hour recalls. So we were interested in the ability of dietary assessment methods to measure usual sodium intake in individuals. And recently, a number of us were involved in a series of systematic reviews comparing dietary assessment methods with 24-hour urine excretion. A number of validation studies and other population-based studies were included in this review. And the main conclusion was that if you use dietary assessment methods in this context, there's a high risk of misclassification of individuals. I've just put a couple of the results there. So food frequency questionnaires, the correlations range from not significant to 0.36, which, as Catherine has indicated, is relatively low. And few studies did Bland-Altman analysis, but the limits of agreement were very wide, so that 95% of participants had estimates that were between -2 grams and +2.5 grams. So those are very wide when you think that the level of the maximum level should be 2 grams of intake. Food diaries and weighed food records, again, very low correlations and no Bland-Altman analyses. A 24-hour diet recall looked a bit more promising, and some of the correlations were higher, but still very wide limits of agreement. But because 24-hour recalls looked a bit more promising, and they're widely used in population nutrition surveys, such as the Adult Nutrition Survey and NHANES, we're currently working on a meta-analysis to determine how accurate 24-hour diet recall is for estimating population intake. And what we haven't got the final data yet, but what we found is that most, but not all, diet recalls underestimate sodium intake compared to 24-hour urine excretion, and this is more likely in overweight and obese participants. But here's some data from one of the validation studies comparing 24-hour diet recall with 24-hour urine. You can see very low correlations here on the left when you're comparing individuals. And when we're comparing group means, you can see that diet and urine estimates differed by almost a gram in men and much lower in women. And again, particularly in men, the difference was larger in overweight and obese men. So what about spot urine? There's been a lot of interest in spot urine as an alternative to 24-hour urine in recent years. The main reason is that 24-hour urine is quite burdensome for participants. It's very labour intensive for researchers, and it's very expensive to undergo, and particularly troubling in some low-income countries. Although Ros and I were just talking before, low-income countries often have higher response rates than high-income countries in this context. So spot urine involves a single collection, and there's an example of what you might collect up there on the top right. My children are always horrified that I show pictures of urine when I talk, but anyway, I think you'll all cope with that. So a single spot urine collection, usually at a random time of day, but some people insist on first morning urine or second morning urine. And then what we would usually do is use an equation to convert the spot urine to an estimate of 24-hour sodium excretion. And there are a lot of different equations, but there are three commonly used equations. There are two derived in Japanese populations and one series of equations derived from intersalt data. And I've included just one example of the sorts of formula we are talking about here. You can see that they're derived from a regression analysis and include sodium and creatinine concentration, sometimes potassium concentration as well, but also demographic factors such as age, sex, BMI. And they usually have limited validity in older adults. But there's a lot of emerging evidence that there is systematic error in spot urine estimates of 24-hour excretion. So here's an example of a recent paper from 2017 in South African population samples, 3 ethnic groups, and they compared the 3 formulae that I've just referred to in spot urine compared to a measured 24-hour urine on the same day. And what they found was that there was systematic error in the 3 formulae that differed. So the Kawasaki formula overestimated excretion by more than 2 grams a day, which is a substantial amount when you're thinking about the target that we're looking for. Tanaka formula overestimated by less than that, and the intersalt formula, the average difference between the groups was 161 milligrams a day, which is much better again, but it overestimated sodium excretion under 5 grams a day and underestimated it over 5 grams a day. So there was a systematic error there. These results also showed that there was limited ability to evaluate public health interventions, and that all 3 formulae performed poorly in their ability to detect an increase in the proportion of the population below the recommended threshold of 2 grams per day. Here's some data from New Zealand, and this is some work I did with Jim and Sheila as part of my PhD. And we did a similar thing, collecting spot urine and 24-hour urine on the same day in a number of healthy volunteers. And you can see in the top row the measured sodium excretion from a 24-hour urine, about 3.5, the mean was 3.5 grams per day. And estimates using the 3 formulae. So Kawasaki formula overestimated by quite a lot. Tanaka was probably the closest, and the intersalt formula seemed to underestimate intake in this population sample. You can also see that the range is greatly reduced using the spot urine estimates, and that's a function of the regression equation. But you can see how that might limit your ability to measure the proportion above and below the suggested dietary target or the upper level. And in our case, we compared what was the UL for sodium intake at the time. We don't have this anymore, but it was 2,300 milligrams per day. And you can see that the three formulae differed quite a lot in their ability to detect the proportion of the population above the UL. And we also looked at the limits of agreement using Bland-Altman analysis. And I'll just highlight perhaps the Kawasaki formula. It showed that for 95% of participants, the spot urine estimate was between just under half of the measured sodium excretion and just over 2.5 times the measured sodium excretion. So there's a substantial amount of both systematic error here and random error demonstrated here. So coming back to this slide of whether spot urine is an appropriate measure, well, we certainly know that it's not reliable and valid. And the extent to which it falls in some of these other categories depends on the question that you're asking. So if you're just interested in the mean, it may be reliable but invalid, but we need to know the extent to which it's invalid. It may also be unreliable but valid, and we need to understand that there's an increased variability or a larger confidence interval or range of plausible values. But if we're looking at spot urine as an estimate of usual intake in individuals, it's D, unfortunately, it's unreliable and invalid. So what do we know about sodium excretion in New Zealand adults? Well, here's some data for using mostly 24-hour urine over time. We have the Milton study in 1975 and 1981, which was more than 90% of the population in the town of Milton, which is just south of Dunedin, about halfway to Balclutha. We have some data using 24-hour urines from Christine Thompson between 1993 and 98 here, and 2012 data from the New Zealand iodine and salt study, which was a sample of adults selected from the electoral roll in Dunedin and Wellington. Sheila Skeef and I did the study, and despite our best efforts, we got a very low response rate. But you can see that overall it looks like we haven't had any change in sodium excretion over the period. The dots here are estimates based on spot urine and the intersalt formulae, which taken from spot urines collected in the 2008-2009 Adult Nutrition Survey. They actually don't look too bad when we're just looking at the mean intake, and hopefully we'll get some updates on those in the next couple of weeks. I know the Ministry has done this again, and I'm looking forward to seeing those results. Sorry, and here's the WHO, or the suggested dietary target here in the green line here. If we compare that with estimated mean intake from the New Zealand Total Diet Survey, you can see that this underestimates intake compared with 24-hour urine. We have men 25 plus years in the orange, we have women 25 plus years in the grey, and men 19 to 24 in the yellow. And you can see this data that the women seem to approach that target, which we didn't see with the 24-hour urine. Okay, so what do we recommend? Well, this is what WHO recommends. Mean population salt intake can be estimated through urinary excretion of sodium. The 24-hour urinary measurement is currently the most accurate method and is recommended if countries have the resources and capacity. If this is not the case, then spot urine may be used as an alternative. And they also say elsewhere that preferably after a validation study has been done in a subsample of participants. So what do I recommend for New Zealand? Well, we've got some pretty good data on baseline 24-hour urine that shows that we are desperately in need of a comprehensive government-led evidence-based sodium reduction strategy. So we need to implement such a strategy. And then what we need to do is evaluate and monitor. So we need regular monitoring of food sources through 24-hour diet recall, and we do need ongoing nutrition surveys. We need to monitor sodium content in food according to specific targets. And the University of Auckland has this lovely NutriTrack database that is perfectly suitable for doing this, and the Total Diet Survey is also a suitable avenue for doing this sort of work. And we need to monitor sodium excretion over time. I think the best approach would be to add spot urine to large nutrition surveys, but to periodically do smaller samples of 24-hour urine collection to answer, so that we can answer the range of questions. What is the mean? What's the proportion above and below the target? Which population groups might be doing better and which populations might be doing worse? One last cautionary note. I just can't help myself. Spot urine is completely inappropriate for estimating usual sodium intake in epidemiological studies. There is substantial measurement error on an individual basis, both random error and systematic error. Epidemiological studies that use spot urine to estimate usual sodium intake are unreliable and much more likely to show a J-shaped curve of association with adverse health outcomes. And if anybody is interested, this paper that I've referenced down the bottom, published last year, is an extremely elegant piece of research that demonstrates that in the Trials of Hypertension Prevention cohort. So public health policy mustn't be made on the basis of such flawed studies, even if they're published in very prestigious journals. So thank you very much. I'd particularly like to thank collaborators and co-authors of some of the research I presented today, particularly Jim, who was my primary PhD supervisor and has continued to be a great mentor ever since. Also the other people listed here. And Jenny Reid, who suggested I look at the spot urine from the Adult Nutrition Survey in the first place. So thank you, Jenny. It's turned into a decade-long interest of mine. So thank you very much.
Thank you very much, Rachel. Is there any questions? Yes, sir.
I just wondered what sort of influence can drinking more water have on the sort of disease risk associated with sodium intake?
It has an independent association. So drinking more water just makes your urine less concentrated. It doesn't mean you can eat more salt.
Other questions? Are you waiting for my question? So, Rachel,
Yes,
do we
Lisa.
know enough about the food composition table and sodium in foods, and is there work to be done there?
One of the problems is there's a lot of variability in the concentration of sodium across individual foods. So bacon, there's a huge variability in the sodium concentration in bacon by brand and how dry the bacon is and who's cured it. And so that's a real challenge with sodium in foods. I can see you nodding there. And there's cornflakes and all sorts of different foods. So no, we don't know enough. If we knew everything, we'd be analysing every food that there is. And that's where the NutriTrack database is really useful, because it takes the data from the nutrition information panels from a huge range of brands. So I think if we can use the NutriTrack data and the Total Diet Survey, that's probably the best approach.
Has it stimulated other questions?
I think Claire Smith, did you give me this lovely picture? I think you sent it to me. So I should have acknowledged you as well.
Okay.
Yeah.
I think for a lot of small companies, they often calculate that from the food composition database. And so although we might get quite good estimates for very large food companies, we need to be careful about those smaller food companies who may actually be using the New Zealand food composition database to get the source of their nutrition information.
Oh, thank you, Claire. Yeah, it's not an area that I'm particularly an expert in. It's Helen Isles and Cleona Nemurk who work on that at the University of Auckland. It's their piece of work, so thanks for that.
Okay, and One last question. How close is the Global Action Plan on track? Because they have 2 more years left, do they not?
2025.
Oh, 2025,
Not very
The
close.
Sustainable
Some
Development
countries are doing better than others, and the countries that are actually doing something about it are managing to lower salt intake. But I mean, New Zealand, we have and the Heart Foundation does a little bit of work with food companies and their project Heart Safe. So it's not that we're doing nothing, but we're just not doing nearly enough. And you can see that we're not doing enough to reduce mean sodium intake. So we need to rattle our dags.
Okay, and on that note, so I just want to thank once again all 3 speakers for some very interesting and informative talks this morning. And we'll close the session with a round of applause, but I would like to have an opportunity to have Jim Mann say a few words before you all head off to lunch. Thank you.